We would now like to move ahead to our next session, after which we will have the closing session. So just the 2 more sessions are remaining. First and foremost, thank you so much to all of you for joining us here and staying with us since morning. I'd now like to hand over the next session to our chairperson, Dr. Edwin Stephen. Dr. Edwin Stephen to chair the next session. The panelists are Dr. Kapil Mathur, Dr. Marun Raj, Dr. Jayantu Das. May we have you joining us on the stage, please. This session is titled Vascular Malformations. Vascular Malformations, chaired by Dr. Edwin Stephen. May I have the panelists joining us on the stage? Thank you. Thank you so much. Over to you, Dr. Edwin.
Good afternoon. Can you hear me? Let's proceed to the next session, which is on vascular malformations. Chairing the session is Dr. Edwin Stephen, who's also the first speaker. He needs no introduction, so we'll proceed to the talk.
Yeah. Is Arvind here? Arvind Kohli? We have an Arvind Agarwal if he'll do for that. But Arvind Kohli, I did see him, but I think he may have left. Yeah, if anybody sees him, please send him on stage. Thank you. Good afternoon, everyone. One advantage of being chairperson and speaker is the mic's mine. And I want to start by saying a big thank you to Deepak, Prabhu, Vimalin, Vycon for giving me an opportunity to speak about a topic that's quite dear to my heart, but yet not fully understood and still in the learning process. So I have no conflicts of interest. I know that other speakers would also be speaking about vascular malformations, and the talk is, I'm going to have to run through for want of time, but it's available for those who want to have a look at it. It's important for one to know the classification when dealing with any form of vascular malformation. If you don't know the classification, it's going to be difficult to manage any malformation, and that's probably prime, a challenge in managing vascular malformations. So KTS in short, or Klippel-Trenaunay, is probably the name given by these 2 French physicians who first diagnosed this problem, and essentially it was known to have a venous and a capillary component, and then the lymphatic came along, and so therefore the name hemolymphatic malformation. But this can be added on with soft tissue and bony enlargements or overgrowths. But the important thing is the last line on that slide, and that is to differentiate it from Park-Weber syndrome, wherein you would have micro AV fistulae. Now, there are a series of limbs that you see here, and the interest in all of this began, or we understood it better when B.B. Lee, Prof. B.B. Lee, who you will hear later on virtually, came and gave us a better understanding of what we were looking at. And in 2016, Lawrence Boom and Philip John also came, and we understood it a little more. These are my patients. I've seen them from about 6 months onwards to what you're seeing here and more. The indications are, some of them are absolute, and these are the ones when they have thrombosis or hemorrhage or infection, or if they have an ulcer. The relative contraindications often are pain, which is often again associated with thrombosis or venous pooling, and they do have functional impairment. CVI will set in if the veins haven't been taken care of, and limb asymmetry, the importance of which I will allude to later on in the talk. Cosmetic reasons cannot be underplayed. So management protocol-wise, what do we do? Most importantly, you need to know what is the classification that you're dealing with. Capillary, venous, lymphatic, is it extratruncular, truncular, and that would then decide how you're going to deal with these problems. Imaging-wise, we still would like to do an ultrasound. All of us are quite proficient at that and very easily available, so therefore that gives you a reasonably good understanding of what you're doing within the limbs. But within the pelvis and beyond, you would need other forms of imaging, and I'll come down to that in a later slide. I would like to stress on the need of D-dimer and platelets in these patients, because a lot of them would have localized intravascular coagulopathy from the pooling of blood and usage of all the coagulation factors. And when they are high or low, depending on which of them that you're talking about, they would need to be treated. Cannot stress enough about height correction, and of course the use of manual lymphatic drainage we have found quite useful. Thanks to help from the physiotherapy department at CMC, we found a lot of reduction in edema in these patients, especially the lymphatic component of it. Good use of sclerotherapy can be done for the superficial varicosities, but a word of caution on the lateral marginal vein, which I will speak a little more about as we come to that slide. With pediatric age group, I prefer not to intervene until the age of 18. But yet you can get another spurt between 18 and 21. In fact, on Wednesday, I've been following up one of these patients in Muscat that I diagnosed with KTS, and in the last year or so, the venous component has increased quite a bit. I didn't have the time to put those slides on, but hopefully can show it to some of you if you're interested. The use of sirolimus does have a role, and that will come up to genetics when I'm speaking towards the end of this talk. We have involved our pediatric orthopedicians with regards to arresting the growth of the epiphyseal plate by intervening there and trying to correct that height reduction, the imbalance there, and definitely a role for multidisciplinary teams. We need to make sure you're dealing with KTS and not Park-Weber syndrome. So that's really important, and that can be done clinically. Imaging-wise, host of imaging. Ultrasound is going to be your mainstay, but you could add various forms of MR venography, arteriography, lymphography, and as we heard Dr. Dekivadi allude to, definitely direct puncture venograms are also useful. So various forms of imaging here. Height correction. I'd like to draw your attention to one of our patients who was quite smart. He put in a flip-flop cut into his shoe and corrected the height. So you don't really need to go to a cobbler to do that. I thought that was pretty smart. And we all know once the spine starts having a deformity, it is a problem. The lateral marginal vein is not a varicose vein as everybody thinks. It's a truncular varicosity, and that needs to be respected because it does not have valves and the media is missing. So therefore, a word of caution when you're going to use foam or going to use endoablation for this particular vein, because it has a high risk of pulmonary embolism. And whatever you ablate thermally, in this case, it will just expand because there is really no smooth muscle to hold that thrombus and occlude it in the long run. It should be, yes, operated on early in children to prevent the height mismatch that will occur. And we have written a paper about this. The details are available in the references. So you need to qualify the types that you are dealing with. We do it under a tourniquet and an Eschmark bandage. Need to be very gentle. They bleed like fury. So if you try and do it without a tourniquet and an Eschmark, you could well end up exsanguinating the patient. And the first patient to the left of the slide is a young girl I had operated on, and unfortunately developed a lymphatic leak. And this took quite a long time to settle. We need to be careful with this because patients can lose their lives to sepsis and cannot be taken lightly. I've already told you about the importance of endoablation in these patients. Bleeding is another problem. That is where the role of D-dimer comes. Patients' D-dimers are high because of the local intravascular coagulopathy. You start them on low molecular weight heparin, and you'll be surprised how wonderfully these areas of bleeding stop. This was a gentleman that we tried to sclero some of the veins in the foot, and this is an unfortunate event where the patient sort of landed up with this dry gangrene. And at one of the international meetings that I was there were 4 cases from Singapore of the same problem. So we need to be a bit careful using foam in the peripheries. With the great saphenous vein, just give me a little more time, please. Thank you. With the great saphenous vein, this is a young girl who had the excision, and then you find that the ulcer is not healing, comes across to us, and then you realize this is a KTS. Compression, we have seen various talks here, need to be started properly, otherwise you can make matters worse. This is a patient whose entire right hemi is vascular malformation, and he had recurrent infections of his KTS limb, went into contracture of the knee, required 4-layer bandaging, healing, a bit of steroids to get rid of that inflammation, and then he got well. So these are 2 recent papers that you can have a look at from 2016 and 2019, which kind of sum up. On the left is the JVS paper, which is an algorithm, fairly simple. I tried to blow it up. I didn't have the time. I just got it a little while back, a few days back. But with the ESVS paper, it has classified it down to various age groups, and I think I've already spoken about that now. What are the challenges? Thrombosis within the veins. You need to keep them on rivaroxaban. A lot of them, I've put them on rivaroxaban, 10 milligrams once a day, and they carry that on lifelong, especially if they're going to have any major surgery. One of the patients had an hemorrhoidectomy and nearly lost her life. So clinicians and surgeons need to be made aware that this anomaly can exist in the GI tract, genitourinary tract, and this remains a problem. Challenged about educating people about this awareness. They can have their hemorrhoids done, but put them on low molecular weight heparin, operate, keep them on it for at least 3 to 10 days, and then stop, otherwise you won't be able to control the bleeding. The future will involve genetic testing and the need for specialty centers for such patients. They need lifelong care, support mentally, physically, for their ongoing problems that they face. So these are some publications that I've had with my colleagues, some references for future reading, and all this knowledge stands on the shoulders of the people that I've worked with. So thank you very much for your attention, and we'll take the questions later on, I believe. Yep. Okay, thank you.
For the next talk, we'll call upon Dr. Sumit Kapadia to talk about endovascular options on vascular malformations. He's joining us virtually.
Very good evening to all our colleagues, friends, seniors. I'll be sharing our procedure and tips about endovascular treatment for low-flow vascular malformations. And since we have a vascular malformations session, we already have renowned speakers taking care of the rest of the things. I'll be sharing an experience regards to low-flow vascular malformation. For malformations, it's important to realize that they are not hemangiomas. And this classic example that I've shown on the photograph shows a hemangioma pre and post medical treatment. Hemangiomas by definition will show regression. Malformations will never regress. We need to decide whether it's a low flow or a high flow. And as I said, they may not resolve on their own. They can be extensive or infiltrative. Sometimes surgical total excision may not be feasible. And even if surgery is done, there may be recurrences. We all know about the classification between vascular tumors, which includes hemangioma, and malformations. These are examples of low-flow vascular malformations, and they can be found at different sites in the body, ranging from the trunk, the limbs and periphery, and also mucosal surfaces. They're classically compressible with the presence of blue visible veins, and there is no thrill or bruit. Investigations for low flow malformations, X-ray may show presence or absence of phleboliths, and MRI is the treatment of, or is the investigation of choice, wherein we'll find lobulated, multiseptated masses. Sometimes we may see internal serpentine-like architecture within them. A CT angiography is usually not required for low flow malformations. When it comes to planning of treatment, it is very essential to delineate or define what kind of a vascular malformation it is. Our traditional approach for these lesions is as follows. A localized one, we can offer surgical removal. If it is localized and shows large venous pools, we go for sclerotherapy. Where there are extensive malformations with longer or larger veins, we do occasionally do the endovenous laser or RFA. And if it's a diffuse variety, we go in for a sclerotherapy. The role of sclerotherapy, because there are multiple sclerosants available, and these are four of the common ones. STS, which is a detergent based, is used mainly for venous malformations. Bleomycin and doxycycline are occasionally used for lymphatic malformation, and alcohol, for its ablative property, is very useful for AV malformations as well as for large venous malformations. All of these work in a similar way by causing irritation of the endothelium, leading to thrombosis and eventual fibrosis and contraction. A few principles that we keep in mind when we treat them: they have to be treated percutaneously, either using a Doppler or a fluoroscopy guidance. We have to confirm presence of blood to ensure that the sclerosant goes within the malformation only. Most of these patients would need multiple sessions at 4 to 6 weeks intervals. And as I described earlier slide, that STS, we use it for the venous malformations. A few examples of the eventual results of how sclerotherapy helps. That's a young boy with a large index malformation, and we can see the sign of compressibility in this patient. He underwent 3 sessions of sclerotherapy, and after 3 sessions, we see more than 90% regression of the lesion. The boy is still under follow-up. That's another example of a palm vascular malformation, again treated with sclerotherapy. That's a patient who has a large extensive upper limb malformation. These patients usually need multiple sessions, following which they do show reasonably good results. Additional measures which we can take: the use of fluoroscopy or cath lab is an adjunctive thing. Some operators do use a contrast study to assess the volume. While giving sclerosant under a cath lab, what we can do to make it radio opaque is the use of STS with lipidiol. And this gives a very good contrast, and it's best used with a negative roadmap technique. And once sclerotherapy is done, if compression bandaging is possible, we should use it wherever possible. These are a few examples of sclerotherapy done at various other regions. That's a masseter muscle malformation. This is again a mixed venous and lymphatic malformation. She underwent multiple sessions of treatment. That's a tongue malformation, which shows reasonably good results after 2 sessions of sclerotherapy. It's another tongue malformation treated with sclerotherapy. And just to show an example of how mucosal malformations have to be treated, that's a scalp vein injected into the tongue malformation. And once we pass in the sclerosant, we look at the sign of blanching. So once we can see the sclerosant leading to blanching of the malformation, that is when we would stop, because if we go ahead further, it can lead to ulcers. So we can actually see blanching in most of the lesion here, and that is when we would stop and maybe move on to the next site. That's one of our complicated patients who has extensive malformation involving the lower limb, the vulva, and that's the patient who presented to us with a large vulval swelling and the limb malformation. She was treated with laser for the larger veins and sclerotherapy for the rest of the malformation. And after 3 sessions, we see that the limb swelling has reduced by almost 50 to 60%, and even the vulval swelling, which originally she presented with, has reduced remarkably. So at the end, a few take-home messages that I would want to give you. Endovascular treatment methods are very effective for these low-flow malformations. It's based on very simple concepts, and the treatment method is also simple. There are different sclerosants available, and we have to choose accordingly. We must inform our patients that multiple sessions would be required, and we as well as patients need to keep a close watch on how they behave. Thank you so much. Sorry we couldn't be there in person, but I hope the message is sent across very clearly. Thank you so much.
Thank you, Sumit. If you're hearing us, that was, yes, certainly simple, loud and clear, and we are missing you here. Prof. Bibi Lee is our next virtual speaker for a good number of us here in the room. He is well known as the man with probably one of, maybe the most knowledge behind vascular malformations the world over. He is director of the Vascular Malformations Center at Washington, D.C., and we can start his talk, please. Thank you.
Good afternoon, ladies and gentlemen. It is a great privilege to share our experiences on AVM management today. I have no conflict of interest. Arteriovenous malformation is one of a congenital vascular malformation as the outcome of defective development of circulatory system with lack of normal capillary system. The lack of critical function of capillary system to maintain the delicate balance among 3 different components of circulation system, namely artery and lymphatics, would result in direct connection between the 3 systems to allow shunting of arterial blood directly to the venous system. Therefore, the hemodynamic alteration affects not only to the arterial and venous, but also lymphatic system as well, so that the AVM lesion would precipitate various degree or extent of cardiac failure, peripheral arterial insufficiency, chronic venous insufficiency, and also lymphatic overload as well. Once the compensatory functions reach their maximum capacity, the decompensation period begins. Arterial system would fail to maintain adequate blood flow to peripheral tissue, distal to the AV fistula, resulting tissue ischemia. The venous system, distal to AV fistula, also fails to hold the normal valvular function against the retrograde blood flow, continuous reflux impede the normal anterior venous flow and drainage. Therefore, AVM is a serious birth defect with profound hemodynamic impact to the entire cardiovascular system, centrally, peripherally, and locally. So that AVM is the most hemodynamic complex type of CVM. Although AVM is relatively rare in comparison to other malformations, AVMs are clinically much more serious than any other lesion to warrant special attention as potentially limb-eating, life-threatening condition. AVM lesion infrequently exist with much more common venous or lymphatic malformation together as a mixed condition known as Parkes-Weber syndrome. Recent discovery of a very causative gene among few inherited vascular malformations give a momentum for better and safe management with more precise diagnosis. And the Parkes-Weber syndrome is one of them. Diagnostic investigation of AVM should be studied with basic differential diagnosis among various AVMs using proper combination of a non-invasive to less invasive tests. Then more specific evaluation to confirm the lesion procedure should follow. Duplex ultrasonography remains the first choice among various tests to initiate the test. Duplex ultrasound study readily differentiates AVM from other lesions, not only with its as a high flow lesion with pulsatile flow. Together with the duplex ultrasound, MRI remains an essential diagnostic for the AVM as well. CT angio can deliver more specific information on AVM status so that it is now further incorporated as one of essential diagnostic assessment AVM. AVM management is generally recommended for early aggressive control with priority over all others given in view of the potential to progress become a life, if not limb-threatening condition. The treatment strategy should be made by fully integrated multidisciplinary team approach, and the proper implementation of various indication criteria is essential to make a proper critical decision for treatment. Surgical excision has long been the most ideal treatment for the surgically amenable lesion with a chance of cure, but a majority are not well localized to allow such complete removal by total excision with minimal mobility. Therefore, surgical excision is no longer the treatment choice across the board, but only for surgically accessible lesions. Newly developed endovascular therapy, various endovascular therapy took over the leading role as an independent treatment modality for surgically inaccessible lesions, also as an adjunct therapy to the open surgical therapy for surgically accessible lesion as well. Indeed, surgical excision is still the most ideal treatment for surgically accessible lesion, especially with newly incorporated pre-operative emboloscopic therapy, which gives a significant improvement of safety and effectiveness. Various emboloscopic therapy agents can be utilized in various combinations, but liquid agents like ethanol are generally considered ideal for the lesion with critical ability to penetrate to the lesion nidus. Endovascular therapy is now treatment choice to majority of the lesions since they are mostly surgically inaccessible lesions. However, thoughtful selection of emboloscopy should be made to minimize its complication morbidity by collateral damage. Ethanol is now used as the most effective agent for treatment of AVM lesion, especially for the surgically unresectable lesion, but ethanol is also well known for potentially fatal complication, and therefore careful use with a minimal and effective amount of agent during each session is warranted. NBCA and butyrosan acrylate awnings are generally inadequate to provide long-term control. It is only ideal as a supplemental to enhance the efficacy of surgical dissection. Coil embolotherapy is also most effective to convert high flow lesion to low flow to make the large lesion more amenable to subsequent therapy, but not appropriate as independent therapy for the AVM lesion. As a conclusion, ladies and gentlemen, AVM should not be handled like other malformation lesion, like a venous lymphatic or hemolymphatic lesion. AVM is warranted with special attention on its precise diagnosis and appraisal, the embryonic hemostasis, preferably through the multidisciplinary approach. AVM should be considered as a potentially life, if not limb-threatening condition, especially on the species type of truncular lesion. Thank you for your attention.
Thank you, Prof. He's not going to be with us virtually as well for the discussions, but I'll field the questions and pass it on what I can't answer. So over to Nupur, who's going to speak to us about the molecular basis for vascular, or is it venous malformations, the basis for future therapy. Over to Nupur.
Good afternoon, everyone. The task that has been assigned to me is to review the literature and the scientific evidence on this. So genetic basis of vascular malformations and targeted therapy. So why do we need genetic testing? Imagine the condition of the parents of a patient, of a baby or a child who was born with these gross malformations all over the body. What questions do run through their mind? Is it something which was passed on by inheritance, or is something which came de novo? Will there be a risk of recurrence in the next child or in the next generation? And if there is a gene involved, can we do something to target that particular gene? These are the questions which have been plaguing scientists for nearly a decade or more. So the various scientists and molecular biologists have worked and dedicated their hard work to this and found these are the major pathways involved in the angiogenesis pathways. the vascular endothelial growth factor, the MEK-IRK, angiopoietin TIE2, transforming growth factor beta, and one pathway which we'll keep coming back to is the PI3K-AKT-mTOR pathway. If you remember nothing else, remember this gene, the PI3K. PI3K stands at the threshold of this angiogenesis and all the signaling pathways. These are lipid kinases that phosphorylate membrane-bound lipids. These and their messengers phosphorylate a majority of downstream targets, the mammalian target or rapamycin, and they upregulate the angiogenesis. This is related to various disorders of overgrowth spectrum, the PROS, the vascular malformations, and even non-vascular lesions. This is where it will come down to, but where we are interested in the angiogenesis pathway is these, the PI3K, AKT, mTOR, and the TIE2. These can be targeted by specific drugs to try and treat these lesions. There are other somatic mutations also. Now, how do you diagnose this? Genetic mutations, you can take a blood DNA, but for somatic mutations, you will need a tissue biopsy. So there are GNAQ mutations, there are TIE2 gene mutations, and other MAPK2K mutations which have been identified. These two drugs have been used since 2010 onwards for various indications, especially in hereditary hemorrhagic telangiectasias. However, compliance was poor, and the lesions, all the symptoms would recur as soon as the drug was stopped. Thalidomide also had its own complications, but it could be used in refractory AVM. Now I'm going to talk about these three drugs which are almost entering into clinical practice. So the sirolimus or rapamycin, miransartib, and alpelisib. These are the three drugs which are almost there in clinical practice. Sirolimus, or also known as rapamycin, was originally used as an immunosuppressant in transplant patients. There are reports saying that the ointment, sirolimus ointment itself, is effective in facial angiofibromas. There are many reports, one of which says that they've tried sirolimus in complicated vascular anomalies and found that most patients have a partial response. However, they can have bone marrow toxicity, cytopenia, gastrointestinal toxicity. So though it is extremely effective, you have to monitor for side effects. Our CMC colleagues have shared their results with sirolimus. They use it at a dose of 0.8 milligram per meter square. They tried it in 25 patients in both superficial and visceral vascular malformations and followed them for 2 years. They've reported 76% have symptomatically better and 6 were lost to follow-up. However, they did notice cytopenia and oral ulcers. Alpelisib is the other drug which can be used, it can be considered. It is already being used by our oncology colleagues in combination with fulvestrant, which is an estrogen receptor antagonist, in treatment of postmenopausal women with hormone receptor positive breast malignancies. So, but it's extremely expensive. A box of Picray, the original molecule, will come to 2,55,000. However, the doses that you need for vascular malformations is much smaller than the cancer treatment doses. Permission was given for compassionate use in patients with PROS syndrome. And finally, along with after the pilot studies, they got the EPIC P1 study, which showed that partial response occurs after 24 weeks, and the volume reduction can happen. A lot of these patients have improvement in pain, fatigue, limb asymmetry, all of this. And the adverse effects were fairly all right. They were not too bad. Diarrhea, hyperglycemia, aphthous ulcers. This is the other experimental drug, miransartib. It is still in experimental mouse models and a few human patients. It is a low-dose AKT inhibitor which cures the PI3K-related vascular malformations in preclinical or human animal models. So now I've talked about these three drugs, but other than this, there are various other places where the targeted treatment can be experimented with. There's tramitinib, various other, this higher generations of sirolimus, so we can go to everolimus. All this is still under study, but it is food for thought. So in conclusion, I would like to say that the era of precision medicine has arrived. This can be used under the correct clinical trial setting as an adjunct to the embolosclerotherapy, which is a traditional form of treatment. The anti-angiogenic and anti-cancer drugs are now available. In the correct doses, we could design trials and see whether they're effective or not. It requires careful patient selection, and maybe it's best done under the multicentric trial or registry basis. So now this provides a new era, a new light in this dark tunnel, where we see multiple patients coming back again and again with so much distress, so much morbidity. This provides us one new light at the end of the tunnel.
Thank you, Nipur, for that, for throwing light on that. Next, I'd like to call upon Dr. Sandeep Raj Pandey from Nepal, who will join us virtually to talk to us about the surgical management of vascular malformations.
Namaste, I am Dr. Sandeep Raj Pandey from Nepal. Thanks for introduction and thanks for invitation by Bhaikan 2022. Hope I could have done it physically, but due to recent US travel, I plan to do it virtually, and I have also some local events in Kathmandu. So my talk today is surgical management of venous malformations. Among vascular malformations, the predominantly venous malformations represent the majority of cases. They form a clinical entity and therefore need clear concepts concerning diagnosis and treatment. See one venous malformation in forearm, just before nearby wrist. So surgery is indicated in isolated symptomatic venous malformations or the following sclerotherapy to improve form or function appearance. So surgical results are a function of the size and location of the malformations. Recurrence following surgery is more common with different malformation and when excised is incomplete. In general, surgery or sclerotherapy is more successful when dealing with pure venous malformation than when dealing with combined malformations, ABM or lymphovenous malformation. A study by Kang and work involving 109 patients with slow flow venous malformations determined that total excision could generally be carried out in venous malformation, but that only partial excision was typically possible for lymphatic and combined vascular malformations, with lymphatic malformation in many cases not being operable at all. According to Hamburg classification, predominantly venous malformations are categorized into truncular and extratruncular forms, with truncular forms distinguished as obstruction and dilatations, and extratruncular forms as limited or infiltrating. This is the type 1 truncular forms, where the marginal embryonic vein was involved. This is a marginal lateral embryonic vein, which is a persistent fetal luminant vessel forming the failure of normal involution. This is surgically exposed marginal vein along the lateral aspect of knee and lower thigh before the surgical excision to control the venous hypertension due to severe reflux caused by avulsiosis condition. This is the type 2 extratruncular venous malformation with the lesion in the right angular region. The lesion is a cluster of primitive vein tissue in infiltrating condition to the surrounding subtissue without direct involvement of the main venous trunks. Mainly surgically exposed lesion which complies with N-butyl NBCA glue. So there are also intramuscular venous malformation, often erroneously called intramuscular hemangioma, which present to pediatric orthopedic surgeons as a different diagnosis of tumor or as a cause of muscle pain. So this is an intramuscular venous malformation in the calf. You can see on the MR. So surgical approaches utilize different tactics and techniques that are adapted based on the pathologic form and type of malformation. One is operation to reduce the hemodynamic activity of the malformation. 2 is operation to eliminate the malformation. 3 is reconstructive operation. A staged surgical treatment is also required in some selected cases. As for type 1, a type of tactic is the operation to drive the venous flow into the total or partial removal of the venous malformation and demonstrated subdivided into 3 different techniques. In this way, the infiltrating as well as the limited forms can be treated. An additional technique is dedicated to the treatment of marginal vein. Approach 3 involves the treatment of venous aneurysm, where a variety of techniques have been successful. This is a venous malformation in the right lower limb involving persistent embryonic lateral marginal vein of leg. So results, long-term follow-up demonstrates positive results in 90% of the cases. This was a young man, waiter, KT syndrome with venous malformation. I did several steps of embolization, sclerotherapy. Then further I also excised some malformation because he was having painful. And finally he got leg before the treatment and after treatment few weeks. And he's doing good today. This is another lymphovenous malformation which are directly excised. Another beautiful lady with KT syndrome having venous malformation leg and foot. So leg was sclerotized, but foot was even painful after sclerotherapy, so it was excised. And I see head now, beautiful foot. So this is another boy, a student, 20-year male, who has this big venous malformation on left side, just above knee. And I did several steps of sclerotherapy and also embolization with polycanal and this lipidol. But he was telling no, he is again having pain and doesn't look good. And we did again the angio, and it was like 90%, more than 95% thrombosed. So with the help of plastic surgeon, we totally excised it, take it out, and he was very happy. So this is the staged one, the venous malformation in right lower limb treated by staged surgery with good results, multiple time, before and after. So this one is also on the one hand, before sclero and excision. Just be happy, excised and good lips. So as a conclusion, I would like to say venous malformations should be treated according to the principles developed during the past decades in vascular surgery, intervention treatment, and multidisciplinary treatment. The days of preemptive conservative treatment should be relegated to the past. Especially skills and experiences are necessary to carry out appropriate surgical strategy, and the required operative techniques should be dictated by the location and type of venous malformation. Surgery, when performed by a surgeon with appropriate experience, is an effective first-line treatment for painful intramuscular venous malformation, offering pain relief in the majority of cases. The majority of lesions are resectable, meaning they can be removed with a margin removing a functional limb. Sometimes resection of a whole muscle is required. Thanks, Vacuum 2022. All the best for Vacuum 2023. Thank you.
Thank you, Sandeep. We have one more talk and then we'll take the questions. And the next talk is on IVC leiomyosarcoma, our 15-year experience. Dr. Titus, please make your way. I'm sure the experience across the hall is limited in this topic as is in the world. And it'll be interesting to see what Dr. Titus has to share with us.
Good afternoon. I thank Venous Association of India and Vascular Surgery Department of CMC for this opportunity. I'll be talking about IVC LMS, our experience over the past 17 years. Retroperitoneal sarcoma, as such, is a rare mesenchymal tumor arising in the retroperitoneum. Among this, approximately 1/5 are leiomyosarcoma. When it looks into leiomyosarcoma, IVC leiomyosarcoma comprises approximately 0.5% of the sarcomas in the body. So it is very rare. But when it comes to IVC, the primary tumor of IVC, LMS contributes approximately 50% of the tumor in the IVC. That's the most common. When it comes to LMS, vascular origin has poorer prognosis compared to the non-vascular origin LMS. In literature, when you look at IVC LMS, there are approximately 400 reported cases are available. In 1890 was the first case reported. Initially, most of the cases were only autopsy reports. In 1951, the first operated IVC LMS was described in Chicago. Over the last 70 years, there were several case series and case reports. In our study is spanned over 17 years, that is from 2002 to 2019, with approximately 2-year follow-ups, we had 15 patients. Like seen in literature, we had more female preponderance. Pre-op imaging, cross-sectional imaging was done in all patients. Cross-sectional CT imaging for metastatic workup done only in 6 patients, the rest had chest X-ray. Pre-op biopsy was done 14 out of 15 patients. Kuloileth et al. Described IVC LMS into 3 subtypes based on its location. The first type is between the bifurcation of the iliac veins to the renal veins. The second type is renal vein to the hepatic. Third, above the hepatic up to the heart. In our series, we had 10 cases in the first type and 5 cases in the second type. For the cases we had IVC reconstruction, we had 6 cases in the first type and 3 cases in the second type. We come to the reconstruction part later on. The operative parameters, I said 9 cases we had reconstruction. There were 4 cases where IVC was ligated. Patch repair was done in 2 cases. On-block excision with adjacent organ was done in 5 cases. 3 had right nephrectomy, 1 caudate lobe was excised, 1 had a left iliac artery involvement which required excision and reconstruction. Graft complication, 1 out of 9 patients had graft complication where there was a graft thrombosis with a duodenal fistula which required reoperation 3 months down the line. When it comes to IVC reconstruction, there were no clear-cut guidelines exist. Transatlantic Australasian Retroperitoneal Sarcoma Working Group last year came with some basic guidelines for IVC reconstruction. It basically for the vein says if there is narrowing, that is less than 50% primary repair, more than 50% patch repair. If there is collateral or complete occlusion, either you can ligate where it is located or you can reconstruct with graft or other options. Keingott et al. In his paper has more classified the reconstruction part into depending upon where the tumor is located. For the type 1, where the tumor is located between the bifurcation and the renal veins, most often IVC can be ligated because there are enough established collaterals for the drainage. Patient may not even develop lymphedema. To assess the established collaterals, there are several parameters available. One is preoperative imaging. There are some studies which quoted like if the patient is symptomatic for more than 1 year and there were no lower limb edema. In some case series, they have injected furosemide intraoperatively after cross-clamping the IVC and see whether the urine output is more than 100 ml per hour. So all these parameters exist to assess if there is collaterals. On the same note, I would like to say most of the or some of the IVC LMS or exophytic tumor may not compromise the lumen. So will there be collaterals? That also we need to keep in mind when we are planning about reconstruction. If there is involvement of the bilateral iliac vein bifurcation, that is between the external and internal iliac, then the collaterals may not establish adequately, so you may have to reconstruct. So most often the reconstruction for type 1 is ligation of the IVC is more than enough. That is again in the same study he has described. When it comes to type 2, that is between the renal vein and the hepatic vein, that's where you have the right and left kidney. Most often these tumors involve the right kidney. In our case series also, we had 3 cases where it is very close to the right kidney where we had to do right nephrectomy. When it comes to left kidney, most often it is the left renal vein which is involved. If the involvement is very proximal, we can ligate the left renal vein. However, if it is much distal where collaterals may not be established, the left renal vein can be reconstructed with various options. Either it can be a prosthetic graft or re-implantation of the renal veins into the graft, or we can even auto-transplant the left kidney. What type of graft we use for reconstruction? Most often in our series or all the cases, we had 9 cases, we had PTFE graft for reconstruction. And what is the patency of the graft? They say if there is pre-operative, the IVC flow is good, then the reconstruction graft patency also is very good. However, we need to look into that. When it comes to, this is Spinelli et al. Showing how the reconstruction of the left renal vein by using a graft into the landing onto the PTFE graft. And again, one more case series where both the right and left iliac veins are re-implanted into the PTFE graft. When it comes to type 3, our experience is minimal. We did not have any cases. However, in literature, it says a patient require a cardiopulmonary bypass or a veno-venous bypass before proceeding with a reconstruction. Most often it requires some sort of liver resection and reconstruction with the PTFE graft. X5O resection excision also described in the literature. This is again Gainkard et al. As shown in his, where a left hepatectomy and the IVC tumor excised and the reconstruction is done with the PTFE graft. Our post-operative morbidity, since it's all case series available in the literature, it's more or less same what is available in the literature. We had 4 cases with clavien dindo grade 3 or more complications. 2 patients developed acute renal failure, where actually we ligated the left renal vein. 1 patient required temporarily renal replacement therapy. However, both the patients recovered well. 1 patient developed pulmonary embolism. This may be a common complication with IVC tumors. There are few suggestions exist for this. One, to place an IVC filter. Other one, getting a proximal control before mobilizing or handling the tumor. 1 patient developed ventilator-associated pneumonia. 1 patient had a reoperation. This is the patient who had a left iliac artery graft thrombosis postoperatively, need to be re-explored. And graft complication I already described. 1 patient developed a duodenal fistula which required operation. Currently patient doing well. 1 patient who had a liver auto transplant post-operation has succumbed to the disease on the 3rd post-operative day. That is our only post-operative mortality, approximately 6.6%. Adjuvant treatment, there is no guidelines exist right now for adjuvant treatment. However, SARS one study proved that there is no advantage with neoadjuvant radiotherapy. In our series, 2 patients received neoadjuvant chemotherapy. There is 1 patient had a concurrent non-Hodgkin's lymphoma, received R-CHOP regime. 1 patient received anthracycline-based neoadjuvant chemotherapy. Adjuvant treatment given for 8 patients, 5 received chemo and 3 received radiotherapy. Currently, the STRAS-2 trial is going on for aggressive retroperitoneal liposarcoma and leiomyosarcoma with neoadjuvant chemotherapy. Other parameters, most of our cases with FNLCC grading are poor biological tumor. Our average tumor size is approximately 10 centimeter. And the surgical margins where the data was available, we had 9 negative surgical margin, 2 positive, and the data was not available in 4 cases. Invasion where en-bloc resection was done, there was only 1 case where the left iliac artery micro-invasion was seen. Others, there was no micro-invasion. Average length of hospital stay was 17 days. Follow-up, our follow-up, like we see in the literature, it's not very great. However, out of the 12 patients whom we had good follow-up, our average duration of follow-up is 3 years, 3 months. Local recurrence is seen in 2 patients and distal recurrence seen in 3 patients. Among the 3 patients, 1 underwent surgical excision, 2 underwent chemotherapy for further treatment. Survival data, again in literature, is very minimal. However, Vankat et al. Compiled all the data which is available in the literature, that is 377 cases, and come up with some available survival data. When we compare our series with them, our median disease-free survival is 1.86 years. In literature is 1 year. Median survival probability is 3.1 years. In literature is 2 to 2.1 years. 1 year overall survival rate is 65%. Time to local recurrence, that is those 2 patients, is 301 days. Time to distal recurrence, those 3 patients, is 1 to 48 days. The key points for IVC LMS, it is a rare tumor, very aggressive tumor. Surgery with R0 resection is the best treatment available right now. Reconstruction of the IVC depends upon location and involvement of the surrounding structures. The role of adjuvant treatment is not established. Currently, surgery plays the major role. Thank you.
Thank you, Dr. Titus. We have about 5-10 minutes for questions. If any from the floor, Ilya Kumar is ready. From the speakers who gave virtual talks, we only have Sandeep from Nepal online.
Okay, so should we start with Sandeep only?
Yeah, please.
Sandeep, hello.
Yeah, hi sir, how are you?
I'm fine. Sandeep, I saw from your talk that you are very aggressive with open venous malformations surgeries. So you don't manage them with endovascular at all?
No, actually, first, I have spoken in every slide. Firstly, I manage them endovascular sclerotherapy embolization. And excision is mainly done for the patient who is having pain or not looking good, the lump there, so we have done. But first step is always endovascular. We can't excise without endovascular treatment, there will be aggressive bleeding.
Yeah, okay. So I got that information that it's only open surgery.
No, I have mentioned those. That topic was like surgical, so I haven't mentioned more about endovascular. But all those cases managed previously endovascularly, then only excision.
Sure, thank you. And one question
Thank
to
you.
Edwin. Edwin, you don't use much lasers for KTS ablation. Mainly do open surgery. Do you in your talk of KTS, do you use a laser ablation for the marginal veins, or lasers for closing the big perforators for KTS?
No, I haven't used lasers. I'm not in favor of lasers simply because I think it will cause burns. The veins are too close, number one, and number two, they're too thin walled. So whatever I have done surgically has been more for the lateral marginal vein excision. Yes, I have done quite a few of those.
Sure.
In terms of the other varicosities, if they have bleeding, then sclerotherapy.
Sure.
But in all of this, what needs to be kept in mind is to make sure that the deep venous system is intact.
Sure.
Otherwise, they'll have problems.
Yeah. Why I asked you this question is we are just writing up a publication and our 10 years experience with endovenous lasers. And we have written down a revised laser protocol, which I presented last year in Vicon. And we found and we think, we got more than now 55 patients with KTS with a follow-up of 16 years now. And we think that open surgery should not be done at all. So totally opposite approach. It's nice to have both the approaches. And what we think that laser really works very well. And is done percutaneously. And we had a single patient with burns.
Yeah, I think there's always many ways to skin a cat,
Yes.
especially in areas where
it crossed the thigh
there
on the
are
top
not too many of the kind and people who are interested in them. So it's always good to exchange notes.
Yes,
Thank
that's
you.
why.
Dr. Edwin here. Dr. Relekmar.
Yes, sir.
I want to add.
I will answer after the talk.
I promised
That
you
was
I
a deal
won't.
I made with him. Yeah, anyway. Go ahead.
Anyway, my question is next for Nupur, Dr. Nupur. Very interesting topic, Dr. Nupur.
Nupur?
My doubt is, at what stage do you give this treatment, what you suggested, like PICRE, in early disease or advanced disease? So advanced stages of the malformation. At what stage you think?
It's on, Nupur. It's on. Just speak.
So I have no personal experience with this. It's mostly a review of the literature. What I found is it's been used for high flow refractory AVM, which keeps recurring despite the traditional embolosclerotherapy.
So they regress, right? It's supposed to regress, hypothetically.
What they found is partial response. It never regresses completely.
Okay.
But it's been tried and patients have reported responses. The advantage is it's oral.
Okay.
And the response apparently has lasted for a while and they've managed to get off treatment.
Can we have some silence in the hall, please? From the back, please. Can we have some silence, please? Thank you.
Thank you. Thank you, Nupur. And just
Nupur, when you're still there. Ilya, one second.
yeah,
One
sure,
second. On PICRE alone, since it was used in women, so literature-wise, is it going to be more efficacious in women or is it not gender-based?
Okay, I haven't come across that, but one food for thought which I found while reviewing the literature, most of the AV malformations, we know that they're tumor, they're hormonal responsive. And especially for women in periods of pregnancy, when, the girls when they grow up and come into menstruation, they seems to evolve very rapidly. So in combination with an estrogen receptor antagonist, if we could try this in the clinical setting, obviously with all the consents, but it's a thought, food for thought.
Yeah, thank you. Ilya?
Next question for Dr. Titus.
Yeah, you can ask the question as he's walking.
Yeah, impressive series we have got. This 17 series of leiomyosarcoma. But my thing is whether we have dealt with any benign tumors like leiomyoma. What will be your approach? Because recently we had a patient with IVC leiomyoma, and without any symptoms or obstruction, incidental finding, but it has caused a complete occlusion of the IVC. So in a situation like that, you still go ahead with the leiomyomas. of the
Our
IVC.
experience with the leiomyoma IVC is, I personally don't have any experience, but if it is causing obstruction, I think we still have to excise. And pre-op biopsy proven as leiomyoma and post-op also leiomyoma?
No. We just have the case. So what will be a general, without obstruction, is a asymptomatic patient as such, found on incidental. Actually, it was suspected to be an adrenal tumor. Then they evaluated, sent to us, then we found it as a suspected leiomyoma. We don't have a tissue biopsy as such.
Okay.
So
again,
is there
when
any
it comes to
protocol in your,
retroperitoneum, compared to all the other body areas, 80% of tumors are malignant counterparts. Compared to everywhere else, it's mainly the benign, then the malignant is very less. So we should be very careful before labeling it as benign and going ahead and say it's a benign and leave it alone. So some preoperative biopsy should be there. And we have a series of approximately 50 cases of retroperitoneal benign tumors. And the retroperitoneal benign tumors we excise when the patient develops symptomatic or sudden increase in size or more than 10% increase in size over the 6 months. That's how the two indications we have for excision of the retroperitoneal benign tumors. But IVC leiomyoma, I personally don't have any experience.
okay, we sent it to the tumor board, but they said we'll follow it up.
Ilya,
not
can
to
you
suggest-
speak into the mic?
Yeah. We sent it to the tumor board for discussion also. So in this thing, whether to go ahead with aggressive like strategy for a malignant tumor. But they said we'll just follow it up with regular imaging after 6 months again. So any panel suggestions for how to manage benign tumors of the IVC? Leiomyosarcoma, there's no question. We are going to resect. So
I think the issue, again, I was involved with some of these cases, and I have done a few since also, but the issue is to make sure you have a biopsy diagnosis. Okay. Only then can you be certain that you have done the right thing. And wherever it is plus minus, it's better to go ahead with excision. But the issue is about the patch, which is something that I picked up more recently, is when you want to patch the IVC, the size of the patch is not in planning to leave the IVC at the same size as what you think you excised. Actually, there's a formula that is there to calculate the patch size, which is almost 4 times the size of the hole that you're going to leave. It almost becomes difficult to create it, but that is what is recommended if you're going to close with a patch. So sometimes maybe it's just better to put an interposition. My question to the House is, in which of these cases would you consider creating fistula in the groin? Anybody? For type 1, type 2, type 3, any preference where you would go ahead and create a fistula, femoral to femoral? Anyone's experience? No? Okay.
My two
yes,
pence.
please go ahead.
My 2 pence is that I don't think, I think general consensus is not to create fistulas for IVCs. Maybe for something infrainguinal, then you might need a fistula. Another question is what kind of anticoagulation or medical therapy you want to give for these patients.
Again, there are no guidelines for anticoagulation.